Yes. It is about a very special course. And when people were asking me about, is there any course coming up in Chennai? Is there any course coming up in Bangalore? Or is there, why the course is not happening at Pondicherry? Okay, these three cities have been the common venues for our workshops. I always cite the example of Kolkata because our courses at Kolkata has been the trendsetter along for the past 2 years. We took the clinical certification in orthopedic manual therapy, a 6 months course, and of course followed by PGDCOCPT, the postgraduate diploma certification in osteomanual and chiromanual physical therapy. And subsequently, upon the successes built by these two courses, we are launching the 2 years program of fellowship in musculoskeletal and manual therapy. It's a flagship course of the AOMPT, and it's the offline equivalent of the FOMT, which previously we have been providing it online due to the lockdown. And of course, it's a clinical course. Depending on each clinical condition, every module and 48 modules dispersed over 2 years. So FMMT, of course, is certified in collaboration with Recovery Rehab Australia. And of course, we are stepping into 2025 with our sessions beginning from February 22-23, the Saturday and Sunday at Hotel Aston International, Kolkata. So in line with our trend, of course, the pre-course webinar, before we conduct an offline training program, we always take an online session. We also circulate the online video study materials so that participants are aware of the theoretical content. They also get an idea of the fundamental base. So the practical and the clinical orientation will be better in the hands-on training at Kolkata. Importantly, Dr. Ritu ma'am has been the lead our team not only as a president but also as a learner, the chief learner. If I have to tell myself as chief instructor, it is Dr. Ritu ma'am who is always the chief learner, okay, and the primary learner right from the front. So it's apt that madam's webinar, and of course she made the PowerPoint upon such a very short notice. And definitely madam is happy to share her slides and her presentation as a lecture presentation in the beginning. And of course, then we move on to the some of the points that is we have to consider when we are approaching the term posture, because there are a lot of misconceptions about posture. We all think that posture means it's only the ergonomic side of it. In case of the man, the task, the environment. So that means the patient or the client, the task, and the environment. This triple, the triangle one is actually the interaction is the ergonomics. But you should think first of all that every day we are all under the influence of posture. And it's not just the conventionally whatever we used to think of static posture. We have dynamic postures and we have functional postures. If I am in sitting job, whether my sitting is going to affect me depends upon how that flexion, because sitting means flexion for the lumbar spine. So how that flexion translates into other activities also. Because I might do more of a side lying, or I might do more of a forward bending, or I might do more of a squatting. In different dimensions, these all are actually flexion. We can't say that sitting alone is the cause for the back pain unless and until we understand the pathomechanical interaction in our body between the different structures, the different functions, and the different regions, which we actually decode as the structural interdependence, functional interdependence, and the regional interdependence. And the simplest of the regional interdependence is the role of cervical spine on the foot, role of the foot on the cervical spine. So you correct the position of the foot, whether the cervical posture is changing. Or if you change the position of the neck, whether the foot posture is changing. Okay, so that is regional interdependence. Functional interdependence, broadly classified into the cranial, visceral, and the somatic. A cranial function could be a vision, hearing, all the special senses, or swallowing, speech, every factor, all the functions that is to do with the cranium, including even swallowing, digestion, all that. Okay, so even breathing also. But if you see visceral, it includes the breathing more because the diaphragm and the abdomen and the lungs. So visceral function is systemic. Okay, multiple systems are there. We have the urinary system, we have the reproductive system, we have the digestive system, we have endocrine systems. We have they are all physiologically interlinked, okay, between each other, not just anatomical. And of course, structural interdependence. It's the various structures in the body, right from articular structures, myofascial structures, neural structures, vascular and lymphatic structures, and of course, structures which in any mode or means will always influence the functions. Okay, so we need to go to the structural decoding in situations where the posture is a fixed deformity. So that's why we classify them into structural postures and functional postures. It's like a scoliosis, for example, structural scoliosis, functional scoliosis. So structural means fixed. Functional is something which is not fixed. That means it changes according to change of your positions, changing of the movements. And for example, when you bend the body, the scoliosis disappears. Or when you side bend, if the scoliosis is getting corrected. Or you keep one foot on a stool, okay, then the scoliosis gets corrected. Or you lift your upper limb, the scoliosis gets corrected. So these all is functional. A foot arch, for example, um, a flat foot. But if you do a heel raise, standing on the toes, during that, if the arch is appearing, it means that it's a functional flat foot. A structural flat foot means even when you do a toe standing, the foot will be flat only. So this is a basic understanding of structural and functional postures. You don't think of posture means deformity, because deformity means it's fixed at bony level. Okay. When we say a lordosis as a deformity versus lordosis is exaggerated, lordosis is obliterated, or lordosis is reversed. So you can use various terminology. And of course, in the lumbar spine, we use the term lordosis because that is what we actually have in our perspective as a secondary curvature after development of the muscle activity in the lumbar spine. So the curvature in the spine develops after the muscle activity develops. So that's why it is secondary curvatures. But there are some alignments in the body like anteversion of the femur. It's a skeletal alignment. The femoral head, the upper end rotation with respect to the lower end of the femur. So that is actually developmental, which could be in the early years of life. And at sometimes it could be even intrauterine developments. Okay. So these everything, for example, shape of the skull is determined by the development that happens before the birth. So if there's a change in the shape of the skull, it's going to alter the cranial mechanics. And when cranial mechanics are altered, visceral will try to compensate, or if visceral is insufficient to compensate, then the somatic system, musculoskeletal system, will also try to cohabitate and try to get a functionally normal human being in our homeostasis. So many people have abnormal postures, but they don't have any symptoms and they don't have any clinical dysfunctions. What do we say by clinical dysfunction? Clinical means when the symptom comes, then only it is clinical. If no symptom, it is subclinical. And at the same time, what is dysfunction? Means altered function. It's called as dysfunction. So it doesn't mean that I have a flattened lordosis, so I am abnormal. Okay. Even if the flattened lordosis is causing weakness of my spinal muscles, still I am not abnormal. Even if I have symptom of low back pain also, I am not abnormal. This thinking first should come. So do not brand the people with the postural deviation or with symptoms as patients, because they are actually same human beings as all of us. As we all have that postural deviation, they are also having. We all have pain which comes and goes. They also have pain that comes and goes. So don't brand them as patients and see them and treat them as a person with a posture deviation, with a symptom, and a person who has a dysfunction, that is altered function. So more than focusing on the posture or the symptom, focus on the function, the functional activity. Because if sitting is affected, treat the sitting. Don't tell them that avoid sitting or don't sit in your comfortable sitting. Sit like this. Okay. Because in that comfortable sitting itself, when symptom was there, your treatment should make the patient sit in the same position, same abnormal comfortable posture without symptoms. That is the treatment. If I am not able to stand for 3 hours, I am getting knee pain. You tell me not to stand or you tell me modify my standing is not a treatment. You should tell as comfortable as you are, you stand. Still, I should not get any knee pain. That is the real treatment. So that functional perspective is the patient-centered perspective, which AOMPT is well known in all our sessions of webinars and also offline courses. And all our offline courses are available online so that we can reach people who want to upgrade themselves beyond the geographical boundaries. That is how Dr. Ritu ma'am came into part of academy, and now academy is part of Dr. Ritu ma'am. Okay, so that is the effort that she has done. And it's always a pleasure to listen to madam and see her PowerPoint, because she makes the PowerPoint slides thinking, even if it's a first year BPT student who is attending our webinar, she or she should understand that. So that is the participant centered education which we are focusing. And we boast proudly that we are the academy in the world to teach the patient centered rehabilitation, so that we treat every person as different. One person who is doing bike riding and having back pain is different from a clerk, office clerk who is sitting and then having back pain. Don't treat them as both are having sitting related back pain, both may be having this problem. Okay. And then give the same techniques to both. Ergonomic interventions, most of them are same. Desk, monitor, chair, okay, foot position, activity breaks. Most of the time what happens is all patients are given the same advice. And if two friends are coming with back pain from the same office, they will see the physiotherapist giving same exercises, same advice. And after that, the computer professional will think, I can teach the others in the office. They will never come to you, because we are not assessing the individual factor why this has caused this dysfunction in this patient, which may be metabolic, which might need a nutrition or dietary advice, or it could be a hormonal one, which could require a different adjunctive treatments. And sometimes everything could be predisposed by the non-organic or the psychosocial components, which none of us can be exempted from. Whether we have pain or not, our brain is always working. If the brain is not working, we are dead. Heart is not working, we are not dead. Okay. It's only cardiac arrest. But brain not working means we are dead. So with that message, keep the biopsychosocial model, but don't go into theoretical aspect of rehabilitation. Think of the real practical patient-centered, functional oriented rehab. And that will be the focus of the FMMT as a whole. Of course, the next two modules in March are clearly highlighting the clinical problem solving, what is called as a treatment-based examination. And then the next module, the fourth one, is actually a kind of functional assessment and treatment, okay, for musculoskeletal disorders. So do not go by the clinical diagnosis alone, go by the patient's diagnosis. That is the dysfunction. So let's listen to Dr. Ritu ma'am and have ourselves enlightened on the posture from A to Z as the existing knowledge that is available. Yes, ma'am.
Yes, sir. Sir,